everyone. I'm Professor Maureen from the University of Texas in Houston, Texas, and I'd like to thank the organizers for giving me and my fellow presenters the opportunity to talk to you about a very cutting-edge kind of therapy in scleroderma. If I could have the first slide. Okay, I'd like to present an overview of cell-based therapy. Now, people are fairly well aware of CAR-T therapy, but actually it's the beginning of what we call cell-based therapies. So the question is, this is something that the University of Texas requires. I'm not making any money out of this. So, what are cell-based therapies? The traditional therapy uses chemicals or biologics. There's oral medications, which are pills. They're small molecules, much, much smaller than a cell. They're taken every day, sometimes several times a day. Or there could be biologics. Now, these are molecules as well, much smaller than a cell. Monoclonal antibodies that block or activate various immune functions. Usually it's given weekly by self-injections under the skin or IV infusions every month or every several months, and I know people in the audience are pretty familiar with this. And then there's cell therapy, and this introduces living cells into the body. These cells then divide inside the body, interact with surrounding tissue, and persist long-term, and that's perhaps an advantage and perhaps a disadvantage. Possibly these cells can last forever, and there's a lot of research being done in the studies of CAR-T and other cell-based therapies to see how long do these cells actually persist. So, an overview of stem cell therapy. First of all, cells are removed from the body. They're purified to identify stem cells. These are naive, not self-reactive, not autoimmune, at least we hope not. They're frozen away. And then this is for the stem cell. High-dose chemotherapy is given to destroy or greatly decrease the immune system. And then the stem cells, hopefully these non-autoimmune, non-reactive cells, are reinfused back into the patient to reconstitute the immune system because, of course, if the immune system is not reconstituted, then people are at risk for developing very severe infections and perhaps even dying from these infections without an immune system. So that's the problem. Severe infections, organ toxicity from the chemotherapy that's given, and depends on the study, but there's a significant mortality. So can we do better? With fewer side effects and better good effects. And that leads us to CAR-T therapy. So in this procedure, the patient's T cells are collected by this procedure called lymphophoresis. And then those cells are genetically modified in the lab with a virus to express a special receptor, the chimeric antigen receptor, that's where the CAR comes from, that recognizes specific proteins on the B cells. And then these cells are reinfused into the body to kill the target cells. They're more effective than monoclonal antibodies like rituximab and other monoclonal antibodies that are directed against B cells. This approach can be used to modify other cell types, something called NK cells, and they can be genetically modified to target more than one molecule. And again, There's an advantage and a disadvantage to that. You don't want to wipe out the body's immune cells. You just want to get the bad actors, the bad cells that are autoimmune. So this is, in general, what it looks like. The patient goes on this, has the lymphocytes removed, the product goes to the lab, the T cells are separated, they're transferred, there's this viral transduction, and the cells are expanded, so you start out with 1 million cells and you end up with 1 billion or more cells, and then they're washed, concentrated, frozen, and they're ready for bedside use. It also involves, as I think our next speaker will describe, 2-3 weeks in the hospital. So this is a cartoon that shows you here, and this is from cancer, because this procedure has been used to treat cancers for an extended period of time, and there's a lot of data from cancer trials about how it works and how well it works and who responds. So here is this T cell. There's the antibody that then gets hooked onto the T cell. And in this case, because it's a cancer slide, here's the B cell that's cancerous. It has a protein on the surface called a tumor antigen. The link on the T cell looks at the antigen and the cell is destroyed. So what's the future of cell-based therapy? One of the problems with CAR T is that it requires use of a patient's own cell. So each infusion is personalized and prepared in a specialized facility, which limits availability for people. If CAR T proves safe and effective, can we develop an off-the-shelf, not specific for an individual patient, but an off-the-shelf product that is prepared from another type of cell that then can be given to anyone? One of the problems with not being able to do that now with a CAR T approach is that if you were to receive somebody else's T cells, that your body, it's like getting a blood transfusion that's the wrong type. Your body would destroy it. There would be a big immune reaction, not a good outcome. But with these other cells, there are some cells that are not identified, so that you can use the same kind of cell type to give to multiple patients. Now I think I am ready with that brief introduction to introduce Dr. Corrado Campochiaro. He's a graduate in medicine at the University Via Salute San Raffaele in Milan. During his training, he did a 3-month internship at the Transplantation Research Center at Harvard Medical School in the US. He then specialized in clinical immunology and then was a clinical research fellow at the Scleroderma unit of the Royal Free Hospital in University College London, where he focused on the care of scleroderma patients. Since then, and since returning to Italy, he's a member of the Young Investigator Group of USTAR, a member of the Scleroderma Interest Group of the Italian Society of Rheumatology, and a member of the study group on microcirculation in rheumatic diseases for EULAR. Currently, he's a consultant in rheumatology and clinical immunology at San Raffaele Hospital in Milan, and a lecturer in rheumatology and adjunct professor in rheumatology and clinical immunology. So I am pleased to introduce him to you, and he will continue in a more detailed talk about CAR T.
Thank you very much. I'm just a person. I swear I'm not like a super-powered person. So I'm trying to make understand this. It's really complicated topic, so I'm trying to make this as simple as I understood it, as I could remember it. So we already have, so we're talking about using this approach that was just told you, so about CAR-T therapies in systemic sclerosis. But why in systemic sclerosis? Because you all know systemic sclerosis very, very, very well. And you know that you've been told many times that the immune system is a big part of your disease. That's why we're talking about using CAR-T therapies for systemic sclerosis. So what we want to impart is that you know that you can have different severe manifestations for systemic sclerosis, but the immune system is responsible for most of what happens in your body. Sorry. And you know there's been updated the recommendations by EULA, which is the European Society for Rheumatology, about what to do when each of the organs are affected. So what the therapies should be used if you have lung, if you have skin, if you have arthritis. But then there's one point in this recommendation that says, if the patient has a poor prognosis, focus on this poor prognosis. Doesn't say to all patients, doesn't say to patients with systemic sclerosis overall, means patients that have really bad systemic sclerosis. In this case, the patient should be referred to really specialized center to think about the possibility of using stem cell transplantation. So far in the recommendation, there's no mention of CAR-T therapy, okay? This was the most recent one. So the patient should go and see a center which is specialized on stem cell transplantation. But why? Because we know that the immune system starts from a really early progenitor, and this progenitor then spreads out and is the cells that differentiate into the different immune system cells. So what we want to target, if we want to target really hard the immune system, is to go to the very background of the immune system, okay? And this is why hematopoietic stem cell transplantation started. Of course, it started in hematological patients as CAR-T therapies. You're seeing this parallelism about stem cell transplantation and CAR-T therapies. So they start with really bad patients from the hematological department with lymphomas, leukemias, really poor prognosis conditions because they are deadly diseases. And we are trying to take this into our field of rheumatology for patients that have poor prognosis, okay? So the parallelism is about having a poor prognosis and hitting hard the immune system, okay? So with stem cell transplantation, the patient is admitted and you receive, as we said before, like chemotherapy, kills the cancer cells, and then is reinfused with stem cell. But why we need the stem cells? We need two parts here. We need to kill the bad players, and we need to reinfuse some good players inside. So in this case, with the hematopoietic stem cell transplantations, we can hit harder with the chemotherapy because the patient will recover because we'll have like some good players then replacing the bad ones. And there are two types of stem cell transplantations. I'm not going to go into details. You can have autologous, means your own cells being reinfused, and the allogenic, means cells from someone else. In systemic sclerosis, we're just talking about autologous, so your own cells are reinfused to yourself. Because with allogenic, which is way more complicated, can even more bad side effects, it's just used for cancer patients. And you can see the indication of stem cell transplantation. You can find the autoimmune disease, and systemic sclerosis is one of the diseases. And what I want to show you, this is basically what we said. You have like the cryopreservation of the cells, the patient is admitted, is being given chemotherapy, then the cells are transplanted, and the patient goes home. This will require staying in the hospital for some weeks. This is not something you can go home. It's not something you can stay for a few days. You need to stay in the hospital admitted for some weeks because you have no immune system. So you cannot go home. There are some requirements. You cannot eat what you want. You need to eat specific foods that should be well cooked. You can see part of your family in some specific environment because the risk is infection, as we said before. And the risk of infection is really high in the first stages where you have no immune system there. And the side effects, as we said, were basically infections, but you can have hair loss with stem cell transplantation because of the chemotherapy, nausea, vomiting, and fatigue. And you can see here that over time, if you focus on patients being transplanted for autoimmune diseases, systemic sclerosis represents a quarter of the patients being transplanted in Europe for autoimmune diseases. The half is multiple sclerosis, which is still sclerosis, but it's a completely different condition. It's a neurological condition. And these were the trials that we know in systemic sclerosis. They've been published, and they show what Maureen just summarized for us. So they work, but there's the risk of mortality, okay? It is not neglectable risk of mortality you may have, 5 to 10% according to the studies, but of course they work well in systemic sclerosis. And we know even from real life data, not just trials, they do work in the long term because they might reset your immune system. When we go to CAR T cell therapy, what we want to do is to focus, rather than on the really progenitor cells, on these bad players, the B cells. Because we know the B cells are not really good in systemic sclerosis. We know they do a lot of things that are really important in a disease. This means antibody production, cytokine production, it means inflammation, basically, and they stimulate other cells. Okay, so we want to hit these cells. And what we want to do is to hit these cells because they interact also with other cells that are key players in the disease, such as fibroblasts, which is the one that helps in getting the fibrosis in the lungs, the fibrosis in the skin. So we want to hit this cell hard, this B cell. So over the years, we came up with some drugs. And they were all, also in this case, drugs that were started in the hematological field. And then we said, okay, if they work in the hematological field, we can use them also in the rheumatological field. And here, some of you might have heard of rituximab. There are some infusions that kill these cells. And over time, they've been going through more biological therapies, eating the B cells. And then we came to CAR T therapies for this. Because the idea was that when we want to kill these B cells, we might not kill all the bad B cells with rituximab or with other biologics. But inside your own body, you have some cells that actually we call, that are good killers. They like killing things. They like killing small cancers. They like killing viruses. They like killing bacteria over your body. So the idea was that why don't we teach these cells that like killing bad things to kill the B cells? So rather than going to another drug, we are teaching your own immune system basically to recognize this and killing them. So that's the why we're using CAR T therapies. So we're taking these T cells and we are teaching them that the B cells should be eliminated. But what happens is, so rather than give you one drug, one shot of drug or repeated shots of drugs here, we give a living drug because these are the cells. So we infuse the cell will eliminate the bad players that we know are the B cells. In this case, they're recognized by the CD19. You've heard the CAR CD19. CD19 is the marker of these B cells. And they migrate in your body, and they can attack the CD19 cells in different parts of your body. Because with the other drugs, such as rituximab and other drugs, they might be effective, but will not go into deep new tissues. They might eliminate the circulating ones, but maybe there's B cells that are inside the lungs, inside the skin, inside some other area, might not be completely eliminated. So that's what's done. So with CAR T therapies, the patient needs the first time to take the T cells. Then we need to make a bit of space for that. The cells are engenderized, so we make them recognize the B cells, the bad players, and they're reinfused. Okay. The patient needs 2 admissions for this. The first one, when we take out the T cells, then the patient can go home for a while the cells have been manufactured, basically. That usually is not in the same place sometimes. It can be in the same place for academic centers that do CAR T cells on their own, or it might be for trials, the cells might need to be shipped somewhere and then gotten back here in the hospital. And then the patient needs to stay in the hospital at least for a couple of weeks for this. Okay, at least for a couple of weeks. And then the patient needs to be nearby the center. In my own hospital, we have a protocol that the patient needs to be within 1 hour for the first few months after this, because the patient might experience some side effects, so we need to look after the patient, okay? Just to tell you, we need to set up all this. And this was the first study that showed that was really successful. That was the study that was then read in all newspapers. We found a cure for many autoimmune disease, but this is the very early stages of the publication, so we know that it works in patients. You can see this is 2024. It's nothing in science, just 1 year or 2 years. We need, of course, to look at this more carefully and everything. And these were the results. Patients with systemic sclerosis got better skin, go better lung, even the antibodies, the bad ones, will go down. So we know that could be really effective. And we know that this could be really enthusiastic. That's why we have many, many trials going on about this. And the trials, though, need to be done in a proper way. This is the list of the inclusion-exclusion criteria. I'm not going through, of course, all this, just telling you this is not for all patients. Because, as I said since the beginning, this is for poor prognosis patients, a patient who have not responded to first-line treatment. We cannot give this to anyone. Will not be safe. It's not ethical to give it to anyone. Okay? We just need to give this in specific patients at some stages. And you can see the inclusion criteria, but you can see the enormous list of exclusion criteria. Just to let you know, these are just what we need to focus on when we need to select patients. And we're taking a lot of time, I know. And these are like even more inclusion-exclusion criteria. That's to tell you how difficult it is to find the right patient for CAR T therapy. Okay, because we need to be safe first. Safety comes first, always. And also this comes with side effects. Because if you want to kill the bad players might have been like so bad that when you kill these bad players, they release a lot of molecules that can cause even more inflammation. So that's why you have these different side effects. We know well the side effects of CAR T from the hematological conditions. We are still learning about the side effects in rheumatological conditions because we have too few patients to say what are the true side effects in the rheumatological field. So these cartoons, as you can see here, they are mostly from patients with lymphoma, leukemia, being treated with the CAR T therapies, okay? So we don't know the exact percentage of the side effects in scleroderma patients specifically because there are too few patients now. We know there can be like some additional toxicities in specific subsets of patients, such as scleroderma patients, because the cells that are attacking the bad place, as the bad place can be in the skin, you can have even a bit of inflammation in the skin soon after. We've been learning this. You can go to specific side effects related to the fact that you have an autoimmune condition rather than hematological conditions. But I'm telling you, this is really complicated. Now we have the first data about trials, because the New England publication, the big one, was not like, this is a true trial, so that's why the science is done to compare and see things. We can see that there were no major side effects that would scare us to keep on going on researching this, not using this right away, because we've seen in 9 patients. 9 patients is nothing. 9 patients is nothing. 9 patients will give us the possibility of going on with the research about this. And this is just a small point about how these therapies can change. You can have not only CAR T, you will have maybe heard of CAR NK. This is other cells of your body that could kill the bad players in a different way. This is even early stages. But that's to tell you that the science is going on, the research is going on, so we'll find like other possibilities, how to engineerize these cells in many different ways to try to reduce the toxicity while keeping the efficacy. And with this, just like all the potential things we could do with the different kind of the cellular therapies we might have even different ways of dealing with the cells, of collecting the cells, and maybe using this solution off the shelf, as we said. So rather than using just your own cells for one patient, and maybe using some cells that could work on different patients. And these are the major points, but just to telling you that we are still in the really early stages. It's really an exciting field because we can find like a really good therapy for systemic sclerosis, but still just to remind you, in some specific patients with a specific focus. Okay, and with this, I thank you all for your time. And I was super late, I know.
Thank you for that excellent talk, and we'll have a chance for questions at the end of all 3 speakers. So next, it is my pleasure to introduce Michael Oeschger. He has been living with scleroderma for 20 years. Early in the course of his disease, significant physical limitations forced him to step away from his work in logistics management. Through long-term physiotherapy and constant rehabilitation, he gradually regained mobility and is now able to work part-time in logistics controlling. He holds a degree in business administration and also is generous with his time. He serves as chairman of the German Scleroderma Association and chairman of the German Scleroderma Foundation. In these roles, he advocates for patient-centered care, early rehabilitation strategies, and empowerment through practical self-management. Please.
Thank you so much, Maureen, for this kind introduction. And thank you both for your very detailed and informative talks. I'm going to speak for the patient community now, and I'm going to focus on CAR T cell therapy, because this was, in the last 2 years, the #1 topic amongst our German community. We overlook around 750 patients with systemic sclerosis, and this is what they have been telling us. So, despite of all the therapies that we luckily have at the moment, systemic sclerosis still remains a serious and complex autoimmune disease. The backbone of the treatment of systemic sclerosis is immunosuppression. Anti-B cell therapies such as rituximab are widely used and known. For some patients, these treatments already work and they stabilize the disease progression, but for others, they don't. Lung involvement may worsen upon immunosuppression. Skin thickening may still progress. Organ complications may still develop. And last but not least, pain and stiffness or even fixed hands or feet may persist. So the quality of life remains significantly impaired. This is where CAR T and the other cell therapies enter the discussion. Not because the existing treatments have failed, but because important unmet needs still remain. So we have heard a lot about the mechanism and how CAR T works. But from a patient perspective, what matters is that these cell therapies represent a shift in treatment. So a shift from a chronic immune suppression to the possibility of an immune reconstitution. A shift from long-term exposure to medication and side effects to a potentially time-limited intervention. A shift towards concentrated short-term but high risk. And perhaps most importantly, a different psychologically decision dynamic. So it's not just a new drug or new drugs. It is a completely different therapeutic model that we have now. So there are early studies. The numbers are still small, but what they have shown that improvements in skin score under CAR T cell happened, a reduction of digital ulcers, and very important, an improvement of inflammatory changes in heart and lungs, which is life-saving. So these findings are very encouraging, but however, we must remain precise. The studies are still very small, of course. The follow-up periods are limited. The regression of established lung fibrosis remains still a major challenge because we still can't reduce what already happens. The damage done is still there. And the long-term durability of remission is still unknown. So CAR T is very promising, but is still experimental at that very moment. So we must avoid over-interpretation, and this is what patient organizations like ours should do. A lot of telephone calls and a lot of emails have come into our perception since the very beginning of using CAR T in lupus. Maybe some of you remember. There have been some lupus patients that have been symptom-free after CAR T cell therapy, but symptom-free does not mean cured. But our telephones rang and people were hoping for a cure, also the scleroderma people. And this is where we have to translate this to the patients. So who can enter a trial? We have heard about that already. I just wrapped up some very important including and excluding criteria. But what does that mean for the patients? So these criteria, as we know, they exist for safety reasons, of course. But from a patient perspective, being told this therapy doesn't make any sense for you in your condition, or you are not eligible, can be one of the most emotional moments. It can feel like being excluded from hope. So we must acknowledge that eligibility is a medical decision, but the impact of exclusion is a deeply personal one. So this psychological aspect has to be respected. So what does this treatment actually involve? We already heard about that. I'm not going into detail. It means it is not a simple infusion. It needs a pre-treatment with a high toxic chemotherapy. That means a temporary vulnerability of the patient. It requires hospital admission. It requires intensive monitoring. It means dependence on a stable medical infrastructure. The first weeks can be emotionally very intense. Patients may feel fragile. They may rely heavily on caregivers. So this is a different type of trade-up, which means not years of moderate burden, but weeks of concentrated intensity. So each eligible patient must consider which type of burden they are prepared to accept. Understanding the risks. I'm not going through the risks again. I just listed them again. Cytokine storm, neurotoxicity, infections, and so on. What does this mean for the patient himself? Beyond the medical terminology, risk means something else. Risk means uncertainty. Risk means fear. Risk means waiting. It means there can be a temporary loss of control, which again means dependence. And still, maybe there may occur some doubt. Was this the right decision I made? So this is a psychological dimension that must not be underestimated. And the long-term safety. So CAR-T hasn't been used for a long time, so there is no long-term data. Patients may ask themselves, will I have a remission at first? Will it work? And if so, how long will this remission last? Maybe for 2 years, maybe for 5 years, or even longer? If a relapse occurs, what's going to happen? Will a retreatment be possible? If not, what happens then? Can we just switch back to immunos, or what are we going to do? Could new autoimmune patterns emerge? And what are the long-term immune consequences? We have to say we simply don't know it yet. So, most important, or very important too, does CAR-T improve the quality of life? The most patient-reported outcomes in this field come from oncology. We don't have many of them in scleroderma. And these outcomes suggest improvements in general health perception, in pain and fatigue, which is also a matter in scleroderma, in emotional well-being, as well as social functioning. So this is very promising. But these data are not from systemic sclerosis. They are from oncology. So we don't have yet strong SSC-specific quality of life data in CAR-T cell therapy. There are other people involved, the hidden impact, the caregivers. CAR T affects not only the patients, but also their families and caregivers. Who are they? Mostly they are partners, husbands, wives, family, children, parents, or friends. Caregivers often need to be present full-time during early recovery. They also experience a psychological stress, logistical challenges, sometimes financial challenges, and sometimes social isolations. When patients are distressed, caregivers are often distressed as well. So CAR T is not only a medical intervention, it is a family event. So future implementation must include a structured caregiver support too. Then the cost question. The estimated costs, again from oncology, are 300,000 to 400,000 per treatment. So this raises fundamental questions. The cost effectiveness, the reimbursement policies, the access equities, differences between countries and regions, and sometimes even patients. So if CAR T proves effective in SSC, who will realistically have access then on a long term? Innovation without equitable access is risking widening disparities. So it's, again, not just a medical discussion, but also a societal one. So let's wrap it up. CAR T represents a potential breakthrough, a new therapeutic concept, and a possible immune reset, but also serious risks, still limited data, restricted access, high costs, and uncertain long-term outcomes. So that means it may become an important option, but not for the whole community, just for selected patients, and this hope must be informed. I'm going to end with this slide. What SSC patients should ask before going into a CAR T or even asking after CAR T cell therapy. Does CAR T make sense for my individual condition? And if so, am I eligible, and why or why not? What are my individual risks? Do I have any alternatives? What happens if my disease returns? How will my caregiver be supported? How will quality of life be monitored? So this is what we should ask ourselves, and especially our doctors. Thank you.
Thank you for that wonderful talk from a patient's perspective, something unfortunately we are paying more attention to these days, but still very essential. Well, we have time for questions. There are some that have been submitted, and we'll go through the first one while you're thinking about questions, but we're happy to take spontaneous questions. So the first question is, does CAR T, A, reverse the disease, B, cure it, or C, stop the progression? What do you think? I will give that to my colleague.
Easy question. So the data that we have so far, they might imply that we may have a way of stopping the disease, definitely, so like from going on, without the need of chronic immunosuppression. So the idea is that you be given this treatment, and then once this treatment is given, you are off your chronic medications for the immunosuppression. This, though, does not imply that you have damage in your organs because of the disease. This will reverse, because it's not like an infusion of something that will go into your organs and will replace the damage you have. Now, I'm telling you that what you've been given, I've been given cells that kill the bad players, but they do not replace your heart, your lungs, your kidneys if they've been bad. So it's not a cure for damage, definitely. What will stop the activity of the disease, maybe without the need of using chronically some other medications. We don't know for how long, though. So we don't know if this will work for us, clearly was mentioned before, for 2 years, 5 years, 10 years, 20 years. We don't know that because we don't have the follow-up in patients. We know from the data from the first trial, the Castle, the one that I told you before, that at least for 1 year, we might suppose that that patients treated with CAR T cell therapies might be off immunosuppression, but we don't know if they would apply to all different patients. This is more likely. We've learned a bit about this with stem cell transplantation. That's why I make always the parallelism with stem cell transplantation, because we've been using stem cell transplantation for a longer period of time, so we know a bit more about that. We know the stem cell transplantation patients who have been transplanted, most of them have been off chronic treatment, but not all of them. Roughly there's an 20 up to 30% of patients that eventually we need to start back something for the disease. And with this, I'm talking about the immunosuppressive treatments, because all of you, the patients, might be also on other treatments. We're not dealing about gastrointestinal issues for sure, like 100%. We're not dealing with maybe Raynaud's phenomenon. We may still experience that after, so we might take some vasoactive drugs for that. Okay, we're talking about the lung fibrosis, the skin fibrosis, which are the two major domains that we look at when we're building these trials.
Yes, I think one of the things that we would like, and I think one of the things that my patients expect, that if they already have flexion contractures of the fingers, they want those to go away, and I've not seen that. There may be some slight reversibility in lung involvement. We never thought that that would be possible, because once the fibrosis is in the lungs, the usual medical dogma was that you can't reverse it, it will stay, the goal is to keep it from getting worse. And we've actually seen some patients with the Scott trial and with other treatments gain a little bit of lung function, not 100%, but actually to gain a few percentages, which is surprising to us because we thought that would not occur. So there may be more reversibility, but I agree with the other two speakers. To call it a cure is the wrong terminology. Okay.
If anything is not clear, we're here to answer the
please,
questions.
yes.
So please, stop us anytime. You know, we are doctors. We of course, we talk with patients every day, but we know that sometimes having your feedback will help us also to explain this to you better. So please.
Aaron Lever from Sweden. At the first conference in Florence, stem cell was the magic word. And there was a lot of discussion about mortality, which was, I think, over 30% at the time. But still, the doctors believed in it. Now, this seems to be the next step. Mm-hmm. Is your belief higher in this specific CAR T principle?
I get your point. So, with every innovation, of course, there's a lot of debate. The problem is also the way the information is conveyed. With stem cell transplantation, there was a cure at the beginning also with that. Now there's a cure with this. Okay, we, all of us in the scientific community, we are strongly believe that this is a great opportunity. So the use of CAR T cell therapies, so the implications they might have for rheumatological patients is a lot. So we think that there could be another chance, a big chance for some patients to be treated in a good way with these therapies. That's why we are enrolling patients in our trials. But as scientists, as physicians, what we think is not really important. We need to see the data. Because I can believe in something, but what I need to convey as information for you is what we've seen, not just me in my center with my 2 patients, with my 3 patients, with my 5 patients. I need to talk in our community, and we need to put the data together, and we need to do something that's really important for us, statistics. If we need to see that the data stay strong after, and there another thing that is basic for science is the reproducibility. If this works just in 1 center, but does not work in other 10 centers, of course, cannot be taken as an instrument for everything. So, to answer clearly to your question, we do believe in this because the rationale, the biological rationale for this is high. So we do believe because the science behind this is high and because it's already been used in hematological conditions, so we know this. It's not completely new therapy. Okay, so the hematology have been dealing with this for longer than we do, and in all the teams for CAR-T therapies, there's always an hematology because we not be given these therapies ourselves to rheumatologists. The therapy is given in the hematological department by hematologists that know more about CAR-T than us because they've been dealing with them for longer, for a lot more period of time. So we do believe in this, but saying that this is like that's why we are keeping this, like, not because we're not excited about this, but that's the way science should go on. So looking at the data, going back to the data, and see how the things go. And then we can add it up a bit of information for our patients.
And stem cell will also continue to be researched.
Yeah, absolutely.
And there's a question. Most trials usually take patients diagnosed under 5 years since onset of disease. How many years since onset qualify for CAR-T? And it depends on the specific protocol that is undergone at that center. The one I'm involved with is 5 years. And that is a difficult discussion. And I'm going to ask Michael to address that a little. If a patient comes to me, the first time I'm seeing them, it's 5.5 years, and they come because they're really interested in, they've read about, they're willing to accept the risks, and I tell them, I'm sorry. So how would you advise that situation?
Well, that's very difficult. Advice, well, we don't give medical advice in patient association anyway.
Yeah.
So I have to say in that situation, ask your doctor and maybe get a second opinion or even a third one. So, but it's very difficult as we don't know much about that. We have to rely on standard protocols to be safe. So maybe nowadays we just have to accept this answer. Maybe in 2 years it's going to be different. So this is what I would say to patients, and get a second or third opinion if it's important.
Yeah. So Corrado, at your center, is it 5 years as well?
Yeah, it's the same.
Yeah. And when we do the trials with CAR-T or any other trials, that initially we want early disease and disease that is clearly progressing, because it's those people for whom we can say after 100 patients or multiple patients have been enrolled that we can measure the response. We can measure the Raynaud's, the skin involvement, the lung involvement, but people who have longer disease duration from a trial point of view might be so stable that in the 1 or 2 or 3 years participating in the trial, we would not be able to ascertain whether they're better or not. They may in fact be better, it might have been good for them. So after the trial period, the exclusion criteria usually becomes more liberal, and you can actually treat patients a little outside what the actual trial required. So, as you said, there's sort of hope down the line. There may be other studies that come up that would be okay for someone with longer disease duration.
And this happens every day. So of all the new medications for scleroderma that have been trialed, they usually have in the early disease stage. But that's because usually also the follow-up of clinical trials is usually 1 year maybe. With CAR-T, some protocols actually have longer period of follow-up because we want to measure also a bit on the longer term. That's been like a bit changed since like these also trials. But usually we measure how the disease goes 1 year after the trial. And we need to compare the two arms. And the first thing we want to know is after this year to have already some clear data to say we should recruit more patients or we should not. Because if the drug is not going well, we need to stop it as soon as possible. That's the idea of a trial. The idea of a trial is to go with safety first. If you see something that is not safe, of course, we need to stop it as soon as possible. That has happened for trials. Yeah. Some trials have been stopped before they finish the observational period on the recruitment of patients, because they were seen there were more side effects in the started drug compared to the placebo, compared to the standard treatment, and they were stopped before. Okay, that's why there are all these criteria for trials.
Yes, there's another question.
Yes, thank you very much. I'm Manon Thijssen from the NVLE from the Netherlands, and we are talking about the SSC in particular now. I'm very curious in how far is the CAR-T research done all over the world with other diseases, and how is cooperation going? It could speed up.
So with other autoimmune diseases, the CAR-T therapies outside?
Yes, I can imagine that it's not only that the CAR-T cell therapy is not only or research done on the SSC. I'm very curious to know cancer or you name it.
For cancer, the research has already been done the previous years. So for like lymphoma, leukemia, these therapies are approved for some specific cancer. That's why now they're trialed in rheumatological conditions. So CAR-T therapies are approved for some specific hematological conditions. They were born initially for children's refractory hematological conditions, and then they went to adult also with hematological conditions. So there's still research about that to refining, as I told you, the technical expertise and so like rather than having the original CAR-T cells, the cells are engineered like better and better to have more efficacy and fewer side effects. That's the research ongoing in the hematological field. In rheumatology, as I told you, like the first publication was 2024. The cohort was composed of patients with systemic sclerosis, but actually the majority were lupus patients, and then there were myositis patients. Yep. These are the three major groups of patients: myositis, scleroderma, and lupus, so all connective tissue diseases. Now there are protocols ongoing also for other rheumatological conditions, even for rheumatoid arthritis. There are some trials that have been proposed for that, even for patients with vasculitis, even from patients with IgG4-related disease, so many other autoimmune diseases. The idea, basically, is that if you have a disease where rituximab was thought as a good drug, given that we are killing the same cells as rituximab but better, that disease might be a suitable candidate for going to CAR-T therapy. Just to make it, I don't know if I made it too simple. Yeah,
and I think the other part of your question was, are we talking to those investigators? And the answer is absolutely yes. We're talking to them. We want to know about efficacy in other diseases, but we also want to know about safety in other diseases. Because there are more lupus patients who have gotten this therapy than scleroderma, and are they seeing a problem in these other patients that we might be seeing as we expand the scleroderma cohort? So yes, we are all very interested and talking to each other. And there's one last question. Someone asked, could you please tell us about T-cell engagers? So I'll take a short stab at that. We've talked about the stem cell transplant with the high-dose chemotherapy, and now the CAR-T and coming CAR-NK, and after that are the T-cell engagers. And one of the advantages to that approach is that it's not preceded by chemotherapy. And it can be done, they tell me, as an outpatient. So stay tuned. We should know what I see as one of the potential problems with the T-cell engagers is that because they lack the chemotherapy ahead of time, you have to give more cells. And I'm not sure it's going to be as effective, but we need effectiveness data from CAR-T and CAR-NK before we sort of rush into T-cell engagers. But it's on the horizon, and it looks very promising. Do you have other?
Yeah, absolutely. We have fewer data for T-cell engagers in autoimmune diseases, so we're still in the early stages. So they might work well, they might be less costly, because you've seen like the costs associated with CAR-T therapies. So without hospital admission, of course, this cost will go down, they will be available for more people, clearly, in the national systems. But we still don't know a lot about this.
Okay, I'm being a bad moderator because we've run over time. But thank you all for your attention. This has been wonderful.
Thank you.